There are things we've discussed, and they were covered quite well, that are in the bill that are intended to reduce health care spending. But in general, they are pushed back in time. They're not as strong as they could be, and Congress has plenty of opportunity to step back from the brink, as they have with the sustainable growth rate for physicians, and keep these things from kicking in. The other thing I will say, though, is that the issue's not going away. One of the things I do with the American Academy of Actuaries is work with their Medicare Steering Committee. Medicare has serious financial problems they're going to hit. The government's taken on more responsibility for paying for health care than it's ever had before. We will face these issues, but this last package of reforms was primarily focused on expanding coverage and doing some other things. The hard battle on how we control cost is going to have to be fought later. Thank you.
I think first, after the two talks, and thank you, Tom, for your comments, we'll throw it open for a bit to the audience for any questions that they may have. Okay. Hank? I think there's a microphone coming your way.
Werner Consulting, and for Dr. Pauly. One of my college professors, Alan Meltzer from Carnegie Mellon, had what he calls the Meltzer's Laws of Regulation, and I don't think these have ever been published, but it's very germane to your point. The three laws are: bureaucrats create regulations, markets circumvent them, regulations are static, markets are dynamic. In time, monopolies are created to exploit the gaps in regulation. Given that, what I think is a very interesting point of view, isn't it hopeless to really try to regulate, to do what the government's trying to do? For example, if the penalties for the mandate are so small that people opt out and say, I'll pay the penalty, as you said, you contaminate the pool and the whole thing collapses. So I just had a very pessimistic view of the ability of the bureaucrats to create regulations, because the markets will always circumvent them.
Well, obviously from my remarks, I'm inclined to agree with you. I'm not a big devotee of Armageddon theories, though. I do believe that you could make community rating work, and they have in some states, although those states tended to be sort of self-selected to be ones with both less serious problems in terms of the uninsured and things like that, and well, I don't know whether we should make value judgments here, but more high-toned regulators, fewer brothers-in-law and things like that. I think of the East Coast relative, say, to the Mississippi Gulf Coast. Hope nobody will be offended, but there's variation in the capability of regulation across the country. My view is not that you couldn't patch up a system that'll work, and I think at least function on a day-to-day basis, so it won't be the end of the world. It's just that there are, I believe, much better ways to deal with the social problem of high-risk people than what the politicians have selected this time round. So that's as far as that part goes. And then I guess I'm with you, and I'm always with Alan Meltzer, that the main adverse consequence, I think, may be not that insurers have blown off the doors in their imagination and innovation. When Hollywood jumped on them for HMOs, they kind of have gone into hiding for about 15 years, but they're starting to, there are green shoots, and they're starting to stick up their heads again, a little bit like whack-a-mole, I guess, but the big fear I have is that the system to regulate insurance will have serious and spreading consequences for innovation generally. To some extent, I think there's a kind of philosophical divide about how much confidence do you place in government officials to manage and monitor innovation versus the private market, and it's pretty obvious where I stand, but I think that's kind of the fork in the road, and when you come to a fork in the road, you should take it. So.
Would you like to, either of you like to comment, Tom?
Sure. If I may, on a purely technical level, and I'm not going to speak to policy, on a purely technical level, you can make guaranteed issue work and not have many of the adverse consequences that are discussed if you truly have a universal and effective coverage mandate. Now, whether such a mandate can be enforced or not is effectively enforced is another issue. I think the concern that a lot of people have about the current package of legislation is it really doesn't attempt to do a uniform enforceable mandate. One of my personal pet peeves is that the guaranteed issue starts in 2014 and the mandate penalties start out quite low and are phased in over a period of years. So you have an opportunity for the adverse selection to occur before the mandate is fully implemented, which, if it does occur, is just going to make it that much harder for the mandate to bring people in.
Alan, do you want to?
Well, just a brief point. I don't have a particular position on what Alan Meltzer said, but I do want to make the point that the fundamental issue here that mandates are designed to address is that we haven't been able to bring down the cost of a health insurance policy to a level that the vast majority of people find both affordable and reasonable. Mark has actually worked on a definition of affordability, and we can all have different ideas of what it means, but I would basically say that you have a real problem if the lowest cost individual policy is on the order of $5,000, or you can only create lower cost policies by increasing the out-of-pocket payments, which I view as a non-solution actually. So you have a problem with these really expensive policies, and then you have to put into place penalties. And my contention is you won't get a satisfactory solution to this problem unless you price the insurance policies at a level that people feel delivers value. And you just can't get around that. So I see this as fundamentally a quick fix, but not one that's going to last permanently if we can't deliver value.